Question 1. A 68-year-old male presents with sudden onset of severe, crushing substernal chest pain radiating to his left arm and jaw. He is pale, diaphoretic, and complains of nausea. His vital signs are BP 90/60 mmHg, HR 110 bpm, RR 22 bpm, SpO2 94% on room air. He has a history of erectile dysfunction and took a medication for it yesterday. What is the most critical contraindication to administering nitroglycerin in this patient? A. His current blood pressure. B. His SpO2 reading. C. His complaint of nausea. D. His history of erectile dysfunction medication use. Answer: D. His history of erectile dysfunction medication use. This question tests your knowledge of nitroglycerin contraindications, especially in cardiac emergencies. The most critical clue is the patient's history of erectile dysfunction medication use within the last 24 to 48 hours, as these medications, like sildenafil or tadalafil, can cause a severe, life-threatening drop in blood pressure when combined with nitroglycerin. While the patient's current blood pressure is low, the use of phosphodiesterase inhibitors is an absolute contraindication that significantly compounds the risk of hypotension, making it the most critical consideration. Always remember to ask about erectile dysfunction medications in any patient presenting with chest pain who might receive nitroglycerin, as this can be a fatal interaction. Question 2. You arrive at a single-vehicle collision where a car struck a tree at high speed. The unrestrained driver, a 30-year-old male, is unconscious and trapped in the driver's seat. Your assessment reveals a strong odor of gasoline, smoke emanating from under the hood, and a rapidly expanding hematoma over his left temple. What is your immediate priority? A. Initiate rapid extrication and move the patient to a safer location. B. Apply high-flow oxygen via non-rebreather mask. C. Secure the patient's airway using a jaw thrust maneuver and insert an oropharyngeal airway. D. Control the bleeding from the temple hematoma with direct pressure. Answer: A. Initiate rapid extrication and move the patient to a safer location. This question focuses on scene safety and immediate life threats in a trauma scenario. The critical keywords are strong odor of gasoline, smoke emanating from under the hood, and rapidly expanding hematoma, which collectively point to an unstable and dangerous scene with immediate potential for fire or explosion. While patient care is paramount, you cannot effectively treat a patient in an unsafe environment, making scene safety the absolute priority. In situations where the patient's life or the lives of rescuers are in immediate danger due to the environment, rapid extrication to a safe zone takes precedence over primary assessment or initial treatments. Remember, scene safety is your first and ongoing assessment, always protecting yourself and your patient from further harm. Question 3. A 4-year-old child presents with sudden onset of high-pitched stridor, drooling, and difficulty swallowing. The child is anxious, sitting upright and leaning forward, tripod position, and has a muffled voice. The parents state the child was playing with small toys. What is your most appropriate initial action? A. Carefully attempt to visualize the airway with a tongue depressor and remove the object if seen. B. Administer nebulized epinephrine. C. Encourage the child to cough and avoid any maneuvers that might agitate them. D. Prepare for immediate intubation due to impending airway compromise. Answer: C. Encourage the child to cough and avoid any maneuvers that might agitate them. This question tests your approach to pediatric airway foreign body obstruction versus epiglottitis. The combination of high-pitched stridor, drooling, difficulty swallowing, and tripod position in a child who was playing with small toys strongly suggests either an airway foreign body or epiglottitis, both of which can lead to critical airway compromise. The most appropriate initial action is to encourage spontaneous coughing, as agitation can cause further airway swelling or dislodge an object into a worse position. Attempting to visualize the airway or intubate without proper preparation and specialized equipment in this scenario can be dangerous, and nebulized epinephrine is not indicated for mechanical obstruction. Your priority is to maintain a patent airway without causing further distress until definitive care can be provided. Question 4. You are managing a 55-year-old male who suffered a full-thickness burn to his entire right arm and the anterior trunk. Based on the rule of nines, what is the estimated total body surface area, TBSA, of the burn? A. 9%. B. 13.5%. C. 18%. D. 27%. Answer: D. 27%. This question assesses your ability to quickly estimate burn surface area using the rule of nines, a critical skill for burn management and fluid resuscitation. For an adult, the entire right arm accounts for 9% TBSA. The anterior trunk, which includes the chest and abdomen, accounts for 18% TBSA. Therefore, adding these two areas together, 9% plus 18%, gives a total estimated TBSA of 27%. Accurate estimation of burn surface area is crucial for determining the severity of the burn and calculating necessary fluid resuscitation, helping to prevent burn shock and improve patient outcomes. Question 5. During a medical call, you find an unresponsive 34-year-old male lying supine on the floor. His respirations are slow and shallow at 6 breaths per minute, and you note pinpoint pupils. There are no signs of trauma. A bystander reports he might have taken some pills. What is the most appropriate initial treatment, assuming you have the necessary medications available? A. Administer 2 mg of naloxone intranasally. B. Apply high-flow oxygen via non-rebreather mask. C. Initiate ventilations with a bag valve mask, BVM, and supplemental oxygen. D. Obtain a blood glucose reading. Answer: C. Initiate ventilations with a bag valve mask, BVM, and supplemental oxygen. This question tests your immediate priorities in managing an unresponsive patient with suspected opioid overdose and respiratory depression. The keywords unresponsive, slow and shallow at 6 breaths per minute, and pinpoint pupils strongly indicate opioid toxicity leading to significant hypoventilation. While naloxone is the definitive antidote, addressing inadequate breathing is always the first and most critical life-saving intervention. Prioritizing assisted ventilations with a BVM ensures immediate oxygenation and removal of carbon dioxide, which directly supports life and buys time for naloxone to take effect or for transport. Always remember that circulation and airway/breathing take precedence over administering an antidote when vital functions are severely compromised. Question 6. A 72-year-old female complains of sudden onset of left-sided facial droop, slurred speech, and weakness in her left arm and leg. Her blood pressure is 180/100 mmHg, pulse 88 bpm, respiration 16 bpm, SpO2 96%. Her last known normal, LKN, was 30 minutes ago. What is the most critical action to prepare for during transport to a stroke-capable facility? A. Administration of aspirin. B. Rapid administration of intravenous fluids. C. Preparation for a comprehensive neurologic assessment at the hospital. D. Strict documentation of the exact time of last known normal and continuous reassessment. Answer: D. Strict documentation of the exact time of last known normal and continuous reassessment. This question emphasizes the time-critical nature of stroke management. The keywords sudden onset, left-sided facial droop, slurred speech, and weakness, and last known normal, LKN, was 30 minutes ago are hallmarks of an acute stroke. For potential fibrinolytic, clot-busting, therapy, The LKN time is the most crucial piece of information, determining eligibility for time-sensitive treatments. While a comprehensive neurologic assessment will happen at the hospital, and maintaining appropriate blood pressure is important, your role in documenting the precise LKN and continuously reassessing for changes is vital for hospital decision-making and patient outcome. Pre-hospital providers play a critical role in preserving brain function by rapidly identifying stroke and ensuring prompt transport and information transfer. Question 7. You are assessing a 19-year-old male who was stabbed in the right side of his chest. He is alert but complaining of increasing shortness of breath. You note absent breath sounds on the right side and tracheal deviation to the left. His skin is cool and clammy, pulses rapid and weak, and jugular veins are distended. What is the most likely underlying condition? A. Simple pneumothorax. B. Flail chest. C. Tension pneumothorax. D. Pericardial tamponade. Answer: C. Tension pneumothorax. This question tests your ability to identify the signs and symptoms of a tension pneumothorax, a life-threatening chest injury. The key indicators are stabbed in the right side of his chest, increasing shortness of breath, absent breath sounds on the right side, and critically, tracheal deviation to the left. The combination of respiratory distress, absent breath sounds on the injured side, and hemodynamic compromise, cool, clammy skin, rapid/weak pulse, JVD, with tracheal deviation points directly to a tension pneumothorax. This condition occurs when air enters the pleural space but cannot escape, causing pressure to build up and shift the mediastinum, impairing cardiac output. Prompt recognition and treatment are vital to prevent circulatory collapse. Question 8. A 45-year-old male is found unresponsive at a construction site. He is apneic and pulseless. Bystanders state he was electrocuted. Your initial action should be to A. Begin chest compressions immediately. B. Attach the automated external defibrillator, AED. C. Ensure the scene is safe and the power source is off. D. Establish an airway and begin ventilations. Answer: C. Ensure the scene is safe and the power source is off. This question focuses on scene safety, particularly in unique hazardous situations like electrocution. The crucial keyword is electrocuted, which immediately signals a potential ongoing danger. Before you can approach or touch the patient, you must absolutely ensure the power source is off and the scene is safe for both you and the patient. Initiating patient care without addressing the electrical hazard puts rescuers at extreme risk of electrocution themselves. Always remember, your safety and the safety of your team are paramount before rendering aid in any hazardous environment. Question 9. You are managing a 28-year-old pregnant patient, 36 weeks gestation, who fell down a flight of stairs. She complains of abdominal pain and you notice dark red vaginal bleeding. Her blood pressure is 90/60 mmHg and her pulse is 120 bpm. The most immediate concern for this patient is A. Ectopic pregnancy. B. Placenta previa. C. Abruptio placendae. D. Supine hypotensive syndrome. Answer: C. Abruptio placendae. This question assesses your understanding of obstetrical emergencies, specifically causes of third trimester bleeding following trauma. The keywords are 36 weeks gestation, fell down a flight of stairs, abdominal pain, and dark red vaginal bleeding with signs of shock, low BP, high HR. This constellation of symptoms, especially after trauma, is highly indicative of abruptio placendae, where the placenta prematurely separates from the uterine wall, leading to significant internal bleeding and fetal distress. Placenta previa typically presents with painless bright red bleeding, and ectopic pregnancy occurs much earlier in gestation. Prompt recognition and rapid transport to a facility capable of managing obstetric emergencies are critical. Question 10. A 60-year-old male with a history of COPD is experiencing an acute exacerbation. He is alert, speaking in two-word sentences, and has accessory muscle use. His SpO2 is 88% on room air. What is the most appropriate initial oxygen delivery device and flow rate? A. Non-rebreather mask at 15 liters per minute. B. Nasal cannula at 2 to 4 liters per minute. C. Venturi mask at 28% FiO2. D. Bag valve mask, BVM, with supplemental oxygen. Answer: B. Nasal cannula at 2 to 4 liters per minute. This question tests your knowledge of oxygen administration in patients with chronic obstructive pulmonary disease, COPD, exacerbations. While the patient is in respiratory distress with low SpO2, patients with chronic CO2 retention, common in severe COPD, can have their hypoxic drive blunted by high oxygen concentrations. The goal is to gradually increase oxygen to achieve an SpO2 target of 88 to 92%, which is best achieved initially with a low-flow nasal cannula. Using a non-rebreather or BVM may deliver too much oxygen too quickly, potentially worsening hypercapnia, excess CO2. The Venturi mask offers precise FiO2 but may be overkill initially. Starting with a low-flow nasal cannula allows for careful titration and monitoring of the patient's response. Question 11. What is the primary advantage of capnography, ETCO2 monitoring, over pulse oximetry in confirming and continuously monitoring endotracheal tube placement? A. Capnography provides a continuous, real-time assessment of ventilation. B. Capnography measures oxygen saturation, indicating adequate tissue perfusion. C. Capnography is less susceptible to motion artifact. D. Capnography detects esophageal intubation immediately and reliably. Answer: D. Capnography detects esophageal intubation immediately and reliably. This question highlights the critical role of capnography in airway management, specifically for endotracheal tube (ETT) confirmation. While pulse oximetry measures oxygen saturation and can be affected by motion, it does not confirm ETT placement in the trachea. Capnography, which measures carbon dioxide exhaled at the end of a breath, provides an immediate and continuous waveform that confirms proper ETT placement in the airway. If the tube is in the esophagus, there will be little to no detectable ETCO2, making it the most reliable method for detecting esophageal intubation immediately after placement. This real-time feedback is crucial for preventing complications and ensuring effective ventilation. Question 12. A 3-year-old child presents with a barking, seal-like cough, inspiratory stridor, and mild fever. The child is not drooling and appears to be in mild respiratory distress. The parents report the symptoms worsened overnight. What is the most likely cause of these symptoms? A. Epiglottitis. B. Bronchiolitis. C. Croup, laryngotracheobronchitis. D. Foreign body aspiration. Answer: C. Croup, laryngotracheobronchitis. This question tests your ability to differentiate common pediatric respiratory emergencies. The combination of a barking, seal-like cough, inspiratory stridor, and mild fever, with symptoms worsening overnight, is classic for croup, laryngotracheobronchitis. Unlike epiglottitis, children with croup typically do not drool and are not in a tripod position. Bronchiolitis usually involves wheezing and crackles, and foreign body aspiration is often acute and may not present with a barking cough. Recognizing the distinct presentation of croup helps guide appropriate prehospital management, which often involves humidified oxygen and transport. Question 13. You are assessing an unresponsive 40-year-old male who was found down in an alley on a cold night. His skin is cold to the touch, and you cannot palpate a carotid pulse after 10 seconds. ECG monitoring reveals ventricular fibrillation, VF. What is the appropriate management strategy based on current guidelines? A. Deliver immediate defibrillation, then begin chest compressions. B. Begin chest compressions and deliver one shock, then reassess. C. Administer one dose of epinephrine, then defibrillate. D. Delay defibrillation until the patient is warmed, then deliver one shock if VF persists. Answer: B. Begin chest compressions and deliver one shock, then reassess. This question addresses the management of cardiac arrest in a hypothermic patient. The key factors are cold to the touch, unresponsive, pulseless, and ventricular fibrillation, VF. While historically warming was prioritized, current guidelines from organizations like the American Heart Association, AHA, recommend standard cardiac arrest management, including immediate chest compressions and defibrillation for VF, even in hypothermia. You should attempt one shock, then proceed with compressions and transport for rewarming. Delaying defibrillation until the patient is warmed is no longer recommended for the initial shock. This ensures that reversible causes are addressed while maintaining vital circulation. Question 14. A 22-year-old male is found unconscious after attending a large party. His skin is pale, cool, and diaphoretic. His blood glucose level is 45 milligrams per deciliter. He has a strong gag reflex. What is the most appropriate medication administration route for this patient? A. Oral glucose gel. B. Intranasal glucagon. C. Intramuscular glucagon. D. Intravenous dextrose, D50. Answer: C. Intramuscular glucagon. This question tests your understanding of hypoglycemia management and appropriate medication routes. The patient is unconscious with a blood glucose of 45 milligrams per deciliter, indicating severe hypoglycemia, but still has a strong gag reflex. Oral glucose is contraindicated due to the risk of aspiration in an unconscious patient with a gag reflex. Intravenous dextrose is ideal, but if N4 is not established or cannot be quickly obtained, intramuscular, IM, glucagon is the most appropriate alternative, as intranasal glucagon is not commonly carried by all EMS agencies and its absorption can be slower. Glucagon stimulates the liver to release stored glucose, raising blood sugar effectively without the aspiration risk of oral glucose. Question 15. You are called to a nursing home for a 90-year-old female complaining of general weakness and confusion. Her skin is warm, flushed, and she has a Foley catheter in place. Her vital signs are BP 88/50 mmHg, HR 118 bpm, RR 24 bpm, SpO 292%, and temperature 101.8 degrees Fahrenheit. What is the most likely underlying condition? A. Dehydration. B. Hypoglycemia. C. Sepsis. D. Acute myocardial infarction. Answer: C. Sepsis. This question challenges you to identify sepsis, which often presents subtly in the elderly. The keywords are 90-year-old female, general weakness and confusion, altered mental status, warm, flushed skin, indicating vasodilation, Foley catheter, a common source of infection, and vital signs indicating SIRS criteria, low BP, high HR, high RR, fever. This constellation of symptoms in an elderly patient, particularly with a potential source of infection like a Foley, is highly suggestive of sepsis. While dehydration and hypoglycemia are possibilities, sepsis accounts for the full clinical picture. Early recognition of sepsis is crucial for rapid treatment and improved patient outcomes. Question 16. During a mass casualty incident, MCI, a patient is found with a severely angulated open tibia fracture and active arterial bleeding. The patient is screaming, "My leg is broken," and attempts to stand. According to START triage guidelines, what color tag should this patient receive? A. Red. B. Yellow. C. Green. D. Black. Answer: A. Red. This question tests your application of START, simple triage and rapid treatment, triage principles in an MCI. The key factors are severely angulated open tibia fracture, active arterial bleeding, and the patient attempts to stand. While the patient is ambulatory initially, the critical finding of active arterial bleeding constitutes an immediate life threat that requires rapid intervention, like a tourniquet, that cannot wait for definitive care. This patient falls into the immediate category, red tag, because their life-threatening bleeding requires immediate intervention to survive. Even if they are able to vocalize, the nature of the injury places them in the highest priority. Question 17. You are assessing a patient who was extricated from a motor vehicle collision. They are unconscious and you note clear fluid draining from their nose and ears. What is the most appropriate initial action regarding potential spinal injury? A. Apply a rigid cervical collar and maintain manual inline stabilization. B. Perform a rapid head-to-toe assessment to determine other injuries. C. Log roll the patient onto a backboard for full spinal immobilization. D. Clear the airway with a suction catheter and position the patient in the recovery position. Answer: A. Apply a rigid cervical collar and maintain manual inline stabilization. This question addresses the critical initial management of a potential spinal injury in a trauma patient. The keywords extricated from a motor vehicle collision and unconscious with clear fluid draining from their nose and ears, suggesting a basilar skull fracture and potential CSF leak, strongly indicate a high risk for spinal injury. The most appropriate initial action is to immediately apply a rigid cervical collar and maintain manual inline spinal stabilization to prevent further injury. While other actions are important, protecting the spine is paramount to prevent permanent neurological damage. This pre-hospital intervention is crucial to stabilize the patient until definitive assessment and care can be provided. Question 18. A 40-year-old male with a known history of chronic alcohol abuse is found unresponsive with shallow respirations. His blood glucose is 60 mg per deciliter. He has no gag reflex. After managing his airway and breathing, what additional medication should you consider administering if available and protocol allows? A. Naloxone. B. Thiamine. C. Activated charcoal. D. Dextrose. Answer: B. Thiamine. This question tests your knowledge of specific considerations for patients with chronic alcohol abuse, particularly when altered mental status is present. The keywords are chronic alcohol abuse and unresponsive with shallow respirations. While his blood glucose is slightly low, 60 mg per deciliter, it's not critically low enough to be the sole cause of unresponsiveness, and the prompt asks for additional medication. Chronic alcohol abuse depletes thiamine, vitamin B1, stores, which can lead to Wernicke-Korsakoff syndrome, a neurological emergency. Administering thiamine prior to or concurrently with dextrose is crucial to prevent or reverse severe neurological complications in these patients, as dextrose administration without thiamine can precipitate or worsen Wernicke encephalopathy. Question 19. You are performing chest compressions on a 6-month-old infant in cardiac arrest. What is the correct depth of compressions for this patient? A. Approximately 1 inch 2.5 centimeters. B. Approximately 1.5 inches 4 centimeters. C. At least 2 inches 5 centimeters. D. Approximately 2.4 inches 6 centimeters. Answer: B. Approximately 1.5 inches 4 centimeters. This question tests your knowledge of correct pediatric CPR guidelines, specifically compression depth for infants. For an infant, birth to 1 year of age, the recommended compression depth is approximately 1.5 inches per centimeters, or at least 1/3 the anterior-posterior diameter of the chest. This depth ensures adequate circulation while minimizing the risk of injury. Knowing the precise depth for different age groups is critical for delivering effective, high-quality chest compressions and improving outcomes in pediatric cardiac arrest. Always remember that proper hand placement and consistent depth are paramount. Question 20. You are managing a 28-year-old male experiencing an acute asthma attack. He is severely dyspneic, has inspiratory and expiratory wheezing, and is speaking in one-word sentences. His SpO2 is 89% on a non-rebreather mask. Which of the following medications is most indicated for immediate bronchodilation in this patient? A. Dexamethasone. B. Albuterol via nebulizer. C. Epinephrine intramuscularly. D. Magnesium sulfate intravenously. Answer: B. Albuterol via nebulizer. This question focuses on the immediate management of an acute asthma exacerbation. The keywords acute asthma attack, severely dyspneic, wheezing, and speaking in one-word sentences indicate a significant respiratory emergency. Albuterol, a beta-2 agonist administered via nebulizer, is the primary and most rapidly acting bronchodilator for acute asthma attacks, providing immediate relief by relaxing the smooth muscles of the airways. While epinephrine might be considered for severe anaphylaxis with bronchospasm, and corticosteroids, like dexamethasone, and magnesium sulfate are used in severe cases, albuterol is the first-line medication for direct bronchodilation. Always remember to prioritize immediate bronchodilation in asthma attacks. Question 21. A 5-year-old child ingested an unknown quantity of household cleaning product. The child is alert, complaining of a burning sensation in their mouth and throat, and has blistering around the lips. What is the most appropriate pre-hospital intervention? A. Induce vomiting with syrup of ipecac. B. Administer activated charcoal. C. Administer milk or water to dilute the substance. D. Contact medical control and prepare for rapid transport to a toxicology center. Answer: D. Contact medical control and prepare for rapid transport to a toxicology center. This question tests your knowledge of managing caustic ingestions. The keywords are ingested an unknown quantity of household cleaning product, burning sensation in their mouth and throat, and blistering around the lips. These signs indicate a caustic, corrosive ingestion. Inducing vomiting and administering activated charcoal are absolutely contraindicated as they can cause further damage to the esophagus and airway. Administering milk or water can help dilute, but contacting medical control and arranging rapid transport to a specialized center is the most appropriate overarching pre-hospital intervention. The priority is rapid transport for definitive care and specialized assessment due to the severe internal damage caustic substances can cause. Question 22. You respond to a 75-year-old male complaining of sudden, severe, tearing back pain radiating to his abdomen. He is pale, diaphoretic, and his peripheral pulses are diminished. His blood pressure is 80/40 mmHg and heart rate is 120 bpm. What is your immediate priority? A. Administer analgesics for pain relief. B. Rapidly transport to a facility capable of surgical intervention. C. Initiate aggressive intravenous fluid resuscitation. D. Perform a 12-lead ECG to rule out myocardial infarction. Answer: B. Rapidly transport to a facility capable of surgical intervention. This question presents a classic scenario for a ruptured abdominal aortic aneurysm, AAA. The keywords are 75-year-old male, sudden, severe, tearing back pain radiating to his abdomen, pale, diaphoretic, diminished peripheral pulses, and hypotensive, BP 80/40 mmHg, with tachycardia. This constellation of symptoms strongly suggests a leaking or ruptured AAA, which is a surgical emergency. While pain relief and fluid resuscitation are important, the most immediate priority is rapid transport to a facility capable of definitive surgical repair, as this is the only treatment that can save the patient's life. Any delay can be fatal, and excessive fluid resuscitation can potentially worsen the rupture by increasing blood pressure. Question 23. You are assessing a patient with a penetrating injury to the right anterior chest. Upon inspection, you note an open, sucking chest wound. What is your most appropriate immediate intervention? A. Apply an occlusive dressing taped on 3 sides. B. Apply direct pressure to the wound with a sterile dressing. C. Cover the wound with a sterile dressing and tape all 4 sides. D. Apply a trauma dressing and immediately initiate positive pressure ventilations. Answer: A. Apply an occlusive dressing taped on 3 sides. This question focuses on the immediate management of a sucking chest wound, open pneumothorax. The keywords are penetrating injury to the right anterior chest and open, sucking chest wound. The most appropriate immediate intervention for a sucking chest wound is to apply an occlusive dressing, example petroleum gauze, plastic wrap, and tape it on 3 sides. This creates a one-way valve, allowing air to escape during exhalation but preventing air from entering during inhalation, thereby preventing the development of a tension pneumothorax. Taping all 4 sides can trap air and worsen the injury. This crucial skill directly prevents a life-threatening complication of chest trauma. Question 24. A patient is in cardiac arrest. After 5 minutes of high-quality CPR and initial defibrillation, the patient remains in ventricular fibrillation. You have attempted venous access twice unsuccessfully. What is the most appropriate alternative route for medication administration, assuming your protocols allow? A. Intracardiac. B. Intramuscular. C. Intraosseous. D. Subcutaneous. Answer: C. Intraosseous. This question tests your knowledge of alternative medication administration routes during cardiac arrest. The key context is cardiac arrest, remains in ventricular fibrillation, and attempted venous access twice unsuccessfully. In cardiac arrest, rapid administration of medications like epinephrine is critical. When intravenous, access cannot be quickly established, the intraosseous (IO) route is the preferred alternative for medication and fluid administration because it provides a non-collapsible access point directly into the bone marrow, allowing for systemic absorption comparable to Intracardiac is dangerous and not recommended, while intramuscular and subcutaneous routes are too slow for cardiac arrest medications. Question 25. An unresponsive 50-year-old patient is found at home with cool, clammy skin, and shallow respirations at 8 breaths per minute. Capnography shows an EtCO2 reading of 60 mm of mercury. What does this EtCO2 reading most immediately suggest? A. Hyperventilation. B. Normal ventilation. C. Hypoventilation. D. Esophageal intubation. Answer: C. Hypoventilation. This question tests your understanding of capnography, EtCO2, interpretation in a patient with altered respirations. The keywords are unresponsive, shallow respirations at 8 breaths per minute, and an EtCO2 reading of 60 mm of mercury. A normal EtCO2 reading is typically between 35 to 45 mm of mercury. An elevated EtCO2 reading of 60 mm of mercury in a patient with slow, shallow respirations immediately suggests hypoventilation, meaning the patient is not effectively exhaling carbon dioxide, causing it to build up in the body. This is a critical indicator of respiratory compromise and requires immediate intervention to improve ventilation. Capnography provides real-time feedback on ventilation status, making it an invaluable tool for airway management.